We're going to discuss the MD Inc. 2017 Spinal Injury Motion Restriction Guidelines. These are based on the South African Best Practice Guidelines published in the African Journal of Emergency Medicine, compiled by David Stanton et al., released in January 2017. Recent studies have looked at the need for spinal immobilization in trauma, looking at what is the best evidence-based practice with regards to immobilizing the C-spine in trauma patients. Obviously, there are certain situations where a patient will most definitely need spinal immobilization, and there are accepted neurological and orthopedic signs and symptoms which indicate a high risk of spinal cord injury. These include pain over the spine on palpation or movement, obvious deformity of spinal column, if there's any unexplained hypotension in the absence of tachycardia, which would obviously indicate that the patient is suffering from neurological shock or spinal shock. Any decreased motor or sensory function in the upper or lower limbs, which would include pins and needles or numbness, and any weakness or loss of movement. If any of these are present, the patient would definitely need spinal injury motion restriction and would need their C-spine to be cleared neurologically once they are in the emergency room. It would be useful to have a tool to identify which patients don't need spinal motion restriction. The Canadian C-spine rule is a reliable and sensitive tool that has been developed to this end. It involves asking 4 questions. The first is determining whether the patient is fit to undergo the testing with the Canadian C-spine rule. The second question looks at high-risk injuries. The third question determines whether it's likely that this is a low-risk injury. And the fourth question determines whether the patient can move their head from side to side without pain. We'll go through it now. The first question, if this is a cooperative patient, that means that the patient is conscious, sober, without any intoxicants or alcohol on board. If the patient is cooperative, you can then proceed to question 2, which is whether there are any high-risk factors present. If the patient is not cooperative, spinal motion restriction is indicated. The second question, is there a high-risk factor present? If any of the high-risk factors are present, this patient would need spinal motion restriction. These factors are an age over 65, any form of neurological deficit, any form of major trauma, a fall of greater than 1 meter or 5 stairs, an axial load, a motor vehicle collision of more than 100 km per hour or a rollover or ejection, a bicycle collision, or a collision with a recreational vehicle, such as a quad bike. If any high-risk factor is not present, one can then move on to the third stage, which is to determine whether there is any low-risk factor present. Low-risk factors indicate that the accident was unlikely to cause spinal injury. The first thing is a fender bender, a simple rear-end motor vehicle collision. If the patient was walking and sitting on scene. If the patient had no neck pain initially and it only developed a couple of hours later, and if there's no midline pain on palpation. If low-risk factors are present, you can then move on to the fourth stage, which is to determine whether the patient is able to rotate their neck 45 degrees, both sides without pain. To do this, you ask the patient to move their head 45 degrees to the left and to the right. You must not assist them in the movement of the head. If they cannot do it, they need spinal motion restriction and radiological clearance of their C-spine once they get to the emergency room. If they can do it, there is no need for cervical motion, spinal motion restriction. Central areas of care in dealing with a potential spinal cord injury. The first principle is that of minimal patient handling. Move the patient as little as possible and move them for a particular purpose. Certain movements are obviously necessary, such as getting them into the ambulance, getting from the ambulance onto the hospital trolley. The second principle is the extrication procedures. If a patient is alert and sober and movement does not induce pain, then the patient should self-extricate. In other words, they can move themselves out of the motor vehicle and then climb onto the hospital trolley. A spine board may be used if the patient is feeling pain to assist them to get out of the car without moving the neck. A Kendrick extrication device is no longer indicated and should be avoided. C-spine immobilization. Hard collars are no longer recommended. Systematic reviews have not shown any benefit in using hard collars in potential spinal injuries, and in fact there is a risk of causing movement of the neck in the application of hard collars. Manual immobilization is recommended. as well as the application of head blocks on the hospital stretcher or on the ambulance stretcher. The patient should be coached to remain still. Spinal motion restriction. Techniques to maintain spinal motion restriction in order of preference are a vacuum mattress. A vacuum mattress is a mattress that is filled with small polystyrene balls that is flexible. Pump is applied, which sucks out all the air and then makes the vacuum mattress very firm, and it adapts to the patient's own anatomy. A scoop stretcher is second in preference. The problem with the scoop stretcher is that it can result in the patient becoming quite cold. However, it has a less risk of bed sores than a spinal board. The third preference is a normal ambulance stretcher. Coach the patient to remain still and attach head blocks to the stretcher. The spine board should only be used to move the patient. It shouldn't be used for transport, and it shouldn't be used in the hospital. If a patient does arrive on a spine board in the hospital, they should be log rolled onto the hospital stretcher and head blocks applied. This is a vacuum mattress. The mattress is filled with small polystyrene balls. The patient is laid onto the mattress. The mattress is tied around the patient. A pump is then attached, which would suck all the air out of the mattress, resulting in the mattress becoming firm. This image is to demonstrate the mattress could even be used to conform to a patient in the seated position and will provide support in that position. This is a scoop stretcher. The scoop stretcher has attachments on either ends, which allow the stretcher to be split and opened up, which allows for easy removal from the patient. As you can see, they're generally made of aluminium, although you do get plastic scoop stretchers these days, which can result in the patient being quite cold. But they are nice to the inclination of the boards on the scoop stretcher does prevent the patient from developing bed sores. Some important points to take cognizance of. Any patient who is undergoing spinal motion restriction needs to be monitored for pressure areas and hypothermia. The scoop stretcher can be cold, and the scoop stretcher can also cause pressure sores. Once the patient is in hospital, they should be moved onto the hospital stretcher. It is important to document the method you use to determine the need for spinal immobilization. In other words, the patient had neurological features, therefore spinal immobilization was done, or Canadian C-spine rules failed to clear the C-spine, therefore spinal immobilization was done. The technique used for spinal immobilization, vacuum mattress and head blocks, or vacuum mattress alone, or hospital stretcher and head blocks, and the fact that pressure care was performed. In hospital, if the patient arrives with a hard collar already on from the pre-hospital environment and the patient needs spinal immobilization, leave the C-spine collar on until the C-spine is radiologically cleared. This is to prevent unnecessary movement of the neck. If the patient arrives on a spine board when they get to the hospital, they should be removed from the spine board by log rolling them onto the hospital stretcher.